Welcome to Your Stories podcast, where we hear candid stories from people conquering cancer. I'm your host, Dr. Don Dizon, and I'm happy to welcome my fellow co-host and friend, Dr. Mark Lewis, to the podcast today. Dr. Lewis specializes in hematology and oncology, but at the heart of his work is patient-doctor communication. He is interested in young onset cancers and hereditary cancer syndromes because Dr. Lewis is also a patient. Before his episodes begin airing next month, I am just delighted to talk to my friend, Dr. Mark Lewis.
Thank you so much, Don. It's a real privilege to be able to speak to you. And I was thinking about my disclosures here. One of them is that you and I are friends. And I think that hopefully will come across in the conversation. And then secondly, you're someone whose communication skills I really admire. We'll talk today about how we're breaking down information barriers that have traditionally separated oncologists from patients. And I think you in particular have embraced new media as methods of doing so. So to be able to talk to you about this is a real thrill.
That's great. And the feeling is entirely mutual. I think we actually first met on Twitter.
We did.
And it developed from there. So getting to it, before we get into your work as a doctor, Mark, you have a rare cancer syndrome. It's called multiple endocrine neoplasia type 1 or MEN1. Like, one of the questions that certainly I've thought about, especially with how open you've been, how did that affect you when you were first diagnosed, and how does it continue to affect you?
Yeah, thank you for asking, Don. I mean, obviously it's affected me physically. I think it's also affected me professionally. So I reached my diagnosis the very first day of my oncology training. And so necessarily, I've seen my entire career through this sort of dual lens, being a patient and a physician. And because I was diagnosed in fellowship, of course, I went immediately to my program directors, thinking that this was going to be a liability or that in some way I would be penalized. And in fact, quite the opposite. It allowed me to, go through my training, trying to hone a sense of empathy. And then the other thing that was really amazing about being open to my colleagues and particularly my faculty is many of them confided in me that they had cancer too. And I've actually been working on a kind of a pet hypothesis. I don't have a whole lot of evidence for this, but I suspect that compared to other specialties, we as oncologists are maybe more likely to experience cancer ourselves. And it's not because of occupational exposure. It's because so many of us are drawn to the field through our families. And thus incur a slightly higher hereditary risk, I suspect, in the general population. So I've never proven it, but just I can tell you the number of people over the years that have come to me and largely in private told me about their own illness has really been striking. And then the fact that these conversations have been largely private has shown me that there is still stigma to admitting that you have a chronic illness, certainly to admitting that you have a hereditary syndrome. And frankly, it's because of that stigma that I realize I'm in a very privileged position to disclose what's wrong with me. Many of my colleagues and certainly many more of my patients are not in a position where they're able to disclose that they've had cancer, that they have a genetic disorder. And I am one of the lucky ones. I know it sounds almost disingenuous to say that, but I'm one of the lucky ones that gets to have a platform. And I take that very seriously. And I look at it as a responsibility.
It's very striking to hear this almost running towards something that you experienced. I naively thought if I did this, that no one would get cancer. And I have been exceptionally proven wrong.
It's so difficult to be completely insulated from this disease, even in a time where, if you're privileged enough, you can really expend a lot of your time and resources on your own health and on your own lifestyle and risk mitigation, but unfortunately never really complete prevention or safety. One of the reasons cancer, I think, is so emotionally resonant to the general public is it has touched nearly every family at one time or another, which of course infuses our work with great meaning.
Yeah, 1,000% agreed with you. You mentioned also just in the start that you came to your diagnosis in your first year of fellowship.
Yeah.
What was that like?
Well, I'll tell you, one of the reasons I empathize with patients I was accused of being a hypochondriac. And in hindsight, I don't blame the poor internist that was assigned to me at Mayo Clinic, because I came to him, my first week of fellowship saying, I think I have a hereditary, tumor syndrome. And he said, what are you specializing in? I said, oncology, and it's, it's understandable that, that might have been mistaken for paranoia. So very briefly, what drew me to the field in the first place is I lost my father to cancer when I was 14. It was sort of the perfect cauldron of that grief and my adolescent angst. This was the mid 90s, grunge was the trendy music, and really, and it sounds, almost immature and childish now, but I sort of pictured, you were talking about, being insulated from cancer. I sort of viewed cancer as this amorphous enemy that I was going to tackle, quite naively, of course. But the beautiful part of the process was my father's oncologist realized I had this interest and took me under his wing. And I got to work in his practice every summer during high school and college. So I got to work in his clinic, and I started as a medical assistant. I was a radiology tech. But the most important thing I did in terms of my development was just follow him, shadow him. And I would watch him interact with patients in a manner that was just so meaningful and rich. And so this was the era of paper charts. And he literally in the margins had all this detail about the patient that had nothing to do with their stage or their treatment history. It was all about them. And so he would walk into the room and very authentically, ask them about, their personal identity. And it was such a insight into the field as a human endeavor. And I found it very, very appealing. And then when I got into medical school, I already knew I wanted to do oncology. Told us first year, because as you know, you go through all the rotations and they quite deliberately make you sample everything. They told us that short of psychiatry, oncology would allow you to have the deepest relationships with your patients. Now, the longevity of those relationships, as you know, is sometimes all too brief. But, my personal experience has been I have these kinships with my patients, ideally over years, that are extremely meaningful and deep. And so with all that said, then I finally got to fellowship, and day one, I had abdominal pain. And self-diagnosis is tricky because at first I thought it was appendicitis. It was sort of localizing to my right lower quadrant. But then I had x-rays, and it was ileus. It was a bowel that wasn't moving. And I had a very high calcium level. And I've often said, Don, it's like when you look at the stars and all of a sudden a constellation pops out at you. It was a pattern. And I recognized finally that there must have been a link between what happened to my father, what was happening to me, and then what had happened to my father's father, my paternal grandfather. So both men had died at young ages of sort of mysterious tumors in their chest. And no one could ever explain it. With my dad, there was some sort of hand waving about secondhand smoke exposure. It was described as an atypical lung cancer. He actually went to his grave, and this is one of the things that really bothers me, thinking, oh gosh, I could have done something differently.
Sure.
But he had suffered from high calcium, and it had never really been, I think, thoroughly worked up. He had bone metastasis, and so I sort of wonder if people just assumed that's where the high calcium is coming from. But actually, his high calcium level had bothered him his entire adulthood. And when I developed high calcium too, I had been through enough medical training at that point to know there's only maybe a handful of conditions that would explain consecutive generations of high calcium. And one of them, you've already mentioned, is multiple endocrine neoplasia type 1. And that's why I had this sort of eureka moment. I was like, I know I'm an oncology fellow. I know I've probably read just enough to be dangerous, but I really think I have this. And then finally, I would say I was extremely fortunate because when I went to my doctor, and again, initially encountered some skepticism, I was able to leverage what I might call professional courtesy and say, hey, listen, you really have to take me seriously. I can't order these tests on myself. I need your help with the workup. And I can well imagine other patients, they don't have that feeling of being on a somewhat level playing field with their physician. And in fact, in my field, which is neuroendocrine tumors, the type of tumors I've dealt with personally, there is on average a 7-year gap between onset of symptoms and correct diagnosis. When you talk to patients, the narrative over and over and over again is the wrong diagnosis, ignored diagnoses, and that unfortunately cultivates some mistrust in our profession that, frankly, I feel it's important to try to reestablish.
Which I think it's probably one of the things that I think about with social media. You just don't know who's going to be hearing your story and learning something really important for themselves without ever having met us? And I think you putting your story out there was just so admirable that way, because you do what I try to do on social media as well. I try to make cancer not scary.
Now, I'll be honest. Often what I'm trying to do is not, advertise something I've discovered, but rather signpost to things that are reliable and that I consider meaningful. The field is brimming with hope. And the line that we're walking is the very careful distinction between hope and hype. But again, being honest with patients about what cancer actually entails. I applaud you because I think you have used platforms that some of our colleagues would say, or frivolous or borderline unprofessional, because you're striving so much to connect with patients, and I really, really admire that about you.
Let's just talk a little bit about you're also a parent.
Yeah.
And having been a son who lost his dad to this condition, what is it like when you look at your kids, and what have you told them, and how are you going to approach the issue of this syndrome that is familial?
The thing about me is I'm part of a dual physician couple. My wife is a pediatrician, and as we discussed before the recording started, she is conspicuously absent from social media because she says I tweet enough for the both of us, which is almost certainly true. But I bring her up because she's an absolutely wonderful partner, and of course is an expert in childcare. And so we did talk early on about. Well, first of all, let me step back and say, even the decision to have children when you carry a genetic condition is obviously freighted with a lot of different concerns. And between when my daughter was born and when I discovered I had MEN1, there were new technologies that came along, one of which is pre-implantation genetic diagnosis. So essentially in vitro fertilization plus some very, very fancy testing. So you select the embryos that, quote unquote, are not defective. And for a host of reasons, including cost and frankly, just our own feeling about the matter, we decided not to do that. And so we knew going into trying to have our second child, there was a 50-50 chance, literally a coin flip, that I would pass on this autosomal dominant inheritance. And to be very honest with you, Don, to an almost philosophical degree, it gave me an existential crisis, because I thought if my parents had used this technology to conceive me, I wouldn't exist. And that was a really kind of bizarre, almost kind of science fiction conceit to
And now we are all living with the consequence of that decision.
That's right. Oh man, yeah. Twitter is the worst place for it. So again, we knew that there was a risk. We frankly felt that MEN1, while don't get me wrong, a horrible illness, still allows you to have quality of life. And one of the key things about the syndrome is the reason it gets transmitted is almost all of us survive into our 30s and 40s and to be old enough.
Isn't that remarkable? That's a remarkable thought.
So to really answer your question, we've been nothing but transparent with my son. And we sort of felt like, I hate the phrase new normal, but we felt like if he knew growing up that he had this, then rather than walking into the buzzsaw of illness that affected his grandfather and his great-grandfather, men that he's never going to know, and even unlike me, he'll have the advantage of foresight. And again, the disease is not necessarily a death sentence. It's almost certain he's going to develop the same hyperparathyroidism and calcium issues that I've had to contend with. But everything else about the disease, interestingly enough, varies from person to person. So there is no, and you'll know this phrase, there's no genotype-phenotype correlation, meaning you can't look at one mutation and say, okay, well, this is what someone's life is going to look like.
Right.
And in some ways, that lack of predictability is a little bit scary, but the flip side of the coin is, and I've told him this many times, it's like, listen, what's happened to me, what happened to your other relatives isn't necessarily going to happen to you. So he's 10 now. His care is built into his normal health maintenance. He actually really likes going in an MRI machine. They give him sort of a bubblegum flavored laughing gas to sort of make him still. And he actually really enjoys it. He actually asked me the other day, he's like, when am I going back for the bubblegum test? And it took me a minute to realize what he was talking about. But no, honestly, the fact that he's growing up with this foreknowledge, I think actually is healthy. And there's other people who have told me, oh, no. You should have waited till he was an adult and then told him or given him the choice to know. And parenting is, you never know exactly how well you've done. in the moment. But I personally feel like I was blindsided. I know my relatives had no clue what was happening to them. And so I guess that's why I felt I'll err on the side of over-informing him.
Mm-hmm. It's interesting that you've mentioned this concept of PGD, pre-implantation genetic diagnosis. When I've spoken about it to young women with a BRCA mutation, for example, and said you can still have kids and da 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 da, it's not this, widely embraced, thank God it's available. It is filled with a lot of thoughts about what does it mean for an embryo to be defective because they don't have the gene.
And it pretty quickly, ushers in the specter of eugenics, right?
Yes.
Which is not a field with a proud history. And don't get me wrong, there are certainly conditions where I can well understand why prospective parents would consider doing it. I am not in any way morally judging everybody who's weighing the pros and the cons. I know you're not either, but you're right. Even when you have a germline condition and someone tells you about this, it's rare that someone just embraces it with unfettered enthusiasm.
Right. And I think that was the point to make. Really, I'm glad you spoke about that. I think it's this fascinating ethical area without a right answer, but it really lends itself to personal choice. Really,
exactly.
And speaking of personal choice, what do you disclose to your patients? And on the flip side, how many people who you see are aware of your personal story before you even walked in the door?
So I am in the middle of an absolutely gorgeous feedback loop right now. So in the information age, and especially because the tumors I deal with are traditionally a little bit rarer, and because of this sort of struggle with self-diagnosis that I mentioned earlier, which is across the board encountered by almost every patient with neuroendocrine tumors, I am sought out by patients because they think, quote, "Oh, he gets it." Now, I am also very quick to tell them, listen, I've had multiple surgeries for this. I have not yet required anything systemic. I've not required chemo. I've not required immunotherapy or radiation. I may need all of these things one day. Right now, I don't. So I'm very quick to tell them that I cannot empathize with anyone that's requiring those modalities. On the other hand, what happens is they'll often Google, neuroendocrine tumors, and somewhere in the results, my name will come up because I've been, disclosing my own nets for years now. And so they basically will self-refer. So I'm a gastrointestinal oncologist. My entire practice at this point is solid tumors of the gut and accessory organs. So probably about half my practice, if I'm honest, is colon and rectal cancer, just by prevalence. And then there's a fair amount of traditional pancreatic adenocarcinoma and gastric and esophageal. But then I would say at this point, about a quarter of my practice is neuroendocrine tumors, which is proportionally speaking a very high fraction. And again, it is so wonderful for the most part to be taking care of patients that feel like my kindred. And on the other hand, I have to tell you, I'm in the process of writing about this as catharsis, which I know you do as well. I had a patient, I won't reveal any of her personal details, but she had MEN1 as well. And we were only a couple of days apart in age. And she would joke that we were twins. And she died in January, very, very suddenly, with extremely aggressive disease. And I have to be honest with you, I always try to emotionally firewall my work from my personal life, but she was so like me that it really, really deeply wounded me. And, I still grieve her loss. And so my point is that it's kind of neat to look into the looking glass and see patients like me and see for the most part they're thriving. That's the positive takeaway. On the other hand, I was looking at this reflection of myself and it became a very black mirror. It became a very grave outcome. So that part has been a little bit challenging to negotiate. But to really answer your question, because patients are so self-advocating and because they have all this information at their fingertips now, the vast majority of them come to me knowing that I have dealt with neuroendocrine tumors and I have MEN1. And I will seldom mention it to someone that doesn't ask about it, because I do not want the visits to be about me or for me to be, pretending like I understand what these people are necessarily going through. But I find these days, most of my new referrals in that particular tumor type are driven by an interest to see someone who's been personally affected by it.
I think that's, probably the best compliment I've ever received as an oncologist is is to be told by a patient, thank you for understanding.
Yeah.
I'm just going to go back to something you had mentioned about this patient of yours who died earlier this year. Certainly, I am also not immune to that kind of loss. You do get exceptionally close to people, and perhaps the hardest situations to survive are the ones where the loss was unexpected or
Yes.
just happened so quickly. So I've answered this question myself about boundaries and borders just to preserve my longevity in the field, knowing there is a line that if I cross it, I will be emotionally devastated.
Yeah.
So for me, it is about funerals. And I don't go to funerals because that is my line. I find it's important for me to say goodbye or to say my piece before the person dies and to get that closure before they die. And I don't go further than that. But how do you approach funerals?
Yeah, well, it's interesting because I think you and I practice very, very similarly, obviously in different domains. But I actually did, at least pre-COVID, attend a lot of funerals. And I'll tell you why. It's because my father's oncologist came to his. And I think that made such an impression on me and my family that I thought, wow, this guy, my father was not just a way of generating revenue for him. He was really a person whose loss he mourns. And I actually really admire your approach too. I think that's a really beautiful that you do that while the person is still with us. I will say, I think the other reason I do it, Don, is I have really struggled with the disconnect between someone being in my practice regularly and then going on hospice and me seldom being able to see them again. And again, pre-COVID, it was not uncommon that I would do a house call, again, for no other reason than really a social visit and to see that person when they were on hospice care, because I think you'll find, and you know this, that a lot of patients say, well, gosh, so used to seeing you as really my de facto primary care doctor during the cancer care. And then all of a sudden, our relationship was abruptly terminated. And now I'm under the care of usually very wonderful physicians, but the hospice medical director, I don't see you anymore. And so I think probably the other reason I used to go to funerals is to reestablish contact with the family, let them know that it was not being, cutting them off, so to speak. It was just frankly arranging the care for the patient that I thought was most appropriate once I had exhausted my ability to help them. So I think that's a problem in oncology that we're still negotiating. How do we, quote unquote, hand off the patient at the end of life without it feeling like we're just, sort of jettisoning them and saying, okay, we're done with you. Because again, it is such a long and emotional relationship.
Those listening to understand that as professionals, we create our own way of doing this work, and that there's not a sole way to say goodbye, and there's not a sole way to manage grief when our patients don't survive. But somehow I think you'd agree, you have to learn your way to do that.
You were so right, Don. And frankly, I don't know about you, I got precious little training on how to do this.
I'm going to change the subject just a little bit because there is a tweet that you posted, and it was that virtue doesn't guarantee health.
Yeah.
And you wrote that about your dad who had died of cancer. Tell me a little bit about how he continues to inspire you and what that tweet, how it informs your approach to oncology.
One of the things I really try to unburden my patients of is shame. And again, I can't help but be informed here by what happened to my father. So my father was 42 when he was diagnosed. It was the ultimate incidental OMA, meaning something that was found during another investigation. So we were moving to the United States. He got a chest x-ray to make sure he didn't have tuberculosis. And it didn't show TB, but it showed this huge mass in his chest. And again, it was described to him rather imprecisely as an atypical form of lung cancer. And my father was not one to stigmatize, but then he started wondering, well, gosh, did this, like I said earlier, did it happen through secondhand smoke exposure? And he lived with that. I mean, he died with that thought that there was something avoidable in his life, in his environment, in his exposures, when in fact it was always in the genes. And so my favorite answer, even though it's a slightly evasive one, and I'm sure this happens to you too, patients come and they say, Doc, why did this happen to me? And I actually take the answer from Siddhartha Mukherjee, who I've often described as the poet laureate of our field. He wrote the Emperor of All Maladies, which is, the definitive history of our field. And then he also wrote the Gene. And in the Gene in particular, he spells out this formula where he says, all of these things that are happening to us are the sum of our heredity, so what we inherit, our environment, our exposures, and then the last one, and this is the key, chance. And I see people underestimate so much that last one. It really translates as bad luck. If you want to get fancy, Shakespeare called it the slings and arrows of outrageous fortune. It just means that there's only so many things that are under our control. And also, it is extremely difficult, as you know, to look at any one case of cancer and know absolutely for certain, okay, I know why this person got this tumor. And lung cancer actually is the perfect example, because now we know that 15% of lung cancer happens in non-smokers, and yet we still struggle to decouple smoking and lung cancer. And as a result, lung cancer patients for many years, and probably still now, I would argue, have suffered from this notion, oh, you did something to deserve this. And nobody deserves cancer. And so the reason I tweeted that, Don, about virtue is Twitter's a very interesting place. To their credit, there are a lot of people on there promoting extremely healthy practices or things that they perceive as important to their lifestyle and their fitness. And I applaud that. But that is not, and you talked about insulation earlier, it's so interesting. That is not a foolproof plan against you having to, deal with malignancy. It's just not. Like to some extent, there is random chance. There's these stochastic events that happen as our cells divide and we copy DNA, and there's mistakes happening all the time, no matter how healthy or virtuous you are. So the reason I use the word virtue is I do not like moralizing malignancy. And again, with lung cancer, and actually had a conversation earlier with someone about hepatocellular cancer, which is in my field. Hepatocellular cancer has far too often been linked to, oh, you must have drank too much, or you've been promiscuous and you've acquired hepatitis. No one deserves any of these things. And yet we really, really struggle to unbraid this notion that cancer is somehow related to misbehavior or sin. And that's, again, where I invoke my father. He was a theologian. He was a minister. And so for him, like the notion of disease was actually pretty intricately tied to his concepts of fate. And we're Protestant, and we do believe in being forgiven. But to some extent, I think he wondered, why is this happening to me? The other thing he wrote in his book, so he wrote a book before he passed, that I thought was so beautiful, is he turned that phrase on its head. And he said, why not me? Because again, being a man of faith, people are like, oh my gosh, this is so unfair. You devoted your life and your scholarship to God. Like, why would you be punished like this? And he flipped it on its head and said, well, I'm not exempt, and neither is anyone else. So he inspires me because although he didn't know medically what was wrong with him, he really dealt with his disease with a whole lot of grace. And his favorite quote of mine, which I've also tweeted and continues to inspire me, is he said, crisis, and here he meant cancer, affords us the opportunity now, however brief or lengthy, to discard the trivial and the shallow and to fill every moment and relationship with meaning, intensity, and value.
I do completely agree with you about this work that I think we as oncologists need to embrace, and it's to get rid of the stigma and the shame. And I do think it's the natural tendency of people discussing cancer with someone who's just diagnosed.
Yes.
Is the need to feel protected. What is it that you did wrong so I don't do it?
That is absolutely the subtext, and it's so rarely acknowledged, right? And also I'll say, I know people mean well. One other part of this, I think, is that it's natural to want to nourish, like literally nourish, your loved one and your friend. And so there's a whole aspect here vis-a-vis diet. And I can tell you, as a gastrointestinal oncologist, and this literally happened to me the other day, I had a young woman in my clinic with colon cancer, and she'd been told the reason this happened to her, she didn't eat enough vegetables. And I found that so heartbreaking. And again, I don't even fully understand her oncogenesis, but I'm pretty sure it wasn't, a deficiency of broccoli. And yet people feel compelled to say that, post-diagnosis, not encouraging healthy lifestyle and eating in general, but telling someone who has already developed a pretty advanced malignancy that this is why this happened to you is just so presumptuous and wrong.
Yeah, and there's nothing to be gained by that. There's absolutely nothing to be gained by that. It's reminiscent of these women with metastatic breast cancer because they didn't give up cake. I'm like, I can assure you, the cake wasn't the reason the cancer came back. And I think if there's anything that people should take away from this, it's to understand you can do everything the books tell you to. You can, exercise 3 hours a day and never eat sugar, only stick to a vegan diet, and I can still see you in my office with a breast cancer.
One of the words I struggle with in cancer research is prevention. Everything else really is about risk mitigation and risk reduction.
So, Mark, you are one of several colleagues who have that unique viewpoint, having, being a patient and being a practicing oncologist. What would you hope patients understood about oncologists?
I think the sort of generic image of the oncologist, sort of us as an abstraction, is these scientists, kind of cold-hearted experimentalists. Even now, when I try to put someone in a clinical trial, occasionally I get, "Doc, you're making me a guinea pig." And I'm like, well, no, actually, focused research, short of blind luck, is the only way forward. It's the only way to make any of this better. And so I guess the other thing I'd like to do is, and you and I are involved deeply in oncology research, is demystify that process a little bit, make it understood that sometimes your best option is a clinical trial and not our current treatments. To our colleagues, I would say that we have done ourselves a little bit of a disservice accepting endpoints that are not meaningful to patients. What matters to patients is overall survival and quality of life. And on the latter, and I've tweeted this too, Don, maybe my least favorite phrase in oncology is manageable toxicity, because almost every time I encounter that phrase, it is someone performing sort of verbal sleight of hand around actually pretty awful side effects that, we've come up with this parlance that it's manageable.
Yeah.
Okay, it's manageable. Would you want these things to happen to you or your loved ones? And the answer is almost always no.
Yeah, if you sort of think that it becomes unmanageable when I have to hospitalize you.
We are trying to make them better. And what I mean by better is live longer and with preserved or improved quality of life. That's ultimately what we're trying to do. Unfortunately, quality of life has been something that's been pretty difficult for us to capture, especially when we try to do retrospective analyses. But I think we are really, really working on that now authentically going forward.
Yeah, it's always been so interesting to reduce quality of life to a percentage.
Yeah, exactly.
It's like, wow, all of that in a number, just one number. And I do agree with you as well. I think we are trying to provide more depth to what we mean by that. So I think you're absolutely on point with that.
And again, Don, you're one of the leading experts about sexual health in oncology. And goodness gracious, I don't know if anything gets less discussed in clinic than that. So again, I admire what you're doing and recognizing that, just because you become a patient doesn't mean you lose your identity as a person or, have to abdicate your relationships. Far from it.
Your stance on universal genetic testing. Tell me what your thoughts are about that. Let's say for people with cancer.
Yes.
And then let's say for people with a family history, for example.
Okay. So obviously we're talking at different levels there, right? So when people have a family history, I think that's a lot more compelling because your pre-test probability, the likelihood that you'll get a result that is meaningful is higher, right? I think where I struggle is this notion that we are ready now for larger scale and population level screenings, largely because, the operating characteristics of these tests are not perfect. And so here's what I'm getting at. And I think this extrapolates back to your original question. If you tell someone that you think that they have pancreas cancer and they don't, that is a bell you cannot unring. And there is enormous psychological harm that is irreversible, in my opinion, in telling someone that. Because then their whole life, they're going to be waiting for the other shoe to drop. They're just going to wait for this pancreas cancer to materialize when it might never do so. Even someone affected with a germline defect. I struggle with the notion that we're ready for that degree of testing just because I don't think the panels are perfect. They're not perfectly comprehensive. And even the, quote, positive signals aren't necessarily translating into disease. I think we have to be very thoughtful about how we do that.
Yes, and I think it's until we achieve that sort of societal change of looking at cancer as either you live through it or you're going to die.
Right.
And it's this dichotomous outcome, unless we can change that. So tell me, Dr. Lewis, as a final question, what motivates you to conquer cancer?
I would say I am so inspired by my patients themselves. What motivates me is the desire, as we've sort of said many times in this conversation, to help them live longer, but be less of a blunt instrument in the process. So right now, the hallmark of many of the treatments I give is I'm just going to flood the system with chemicals. They're going to kill the fastest growing cells they see. And I know we're going to look back on our field in years from now, and this is going to seem like such a primitive and crude way of doing it. So what I'm getting at is I am motivated to become more precise. And I realize precision oncology is a phrase that is kind of loaded. But what I mean by that is giving treatments that hopefully do not deprive, certainly not permanently, the patients of their quality of life and allow them to live longer. That is what motivates me. And even in my career, which is relatively short so far, and hopefully will be a lot longer, I've seen us, come closer to achieving that. I've seen paradigm shifts. Immunotherapy, other targeted therapy is, I think, bringing us so much hope, legitimate hope, that we can get away from these indiscriminate toxicities, control or reduce whatever the tumor burden is, and allow these patients to live better and longer.
I can't imagine a better place to end this. Thank you, Dr. Lewis, for joining us on the podcast today and sharing your story. Hearing the experiences of others can help people cope with the challenges cancer brings. Help others find these inspiring stories by leaving a review of the podcast, and subscribe today on iTunes or Google Play to hear every new episode. Thank you for listening to Your Stories, Conquering Cancer. The participants of this podcast report no conflicts of interest relevant to this podcast. Full disclosures can be found on the episode page on conquer.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.